Well, thank you for inviting me. I've chosen this topic after talking to the organizers, and I'm going to discuss about developing a framework for essentially incorporating new evidence into stroke rehabilitation. And so this is my talk in summary. So if you hear nothing else, just remember this. I'm going to talk about the overall picture of stroke rehab literature, kind of talk a bit about that in context with other groups like brain injury and spinal cord. I'm going to talk about something we've done really well in Canada, and that's the standardization of stroke rehab. We have really done a good job there, and can be really proud of how we've been able to change outcomes by standardizing stroke rehab care. I'm going to talk then about the limits to standardized care, dealing with heterogeneity and the idea of personalized care, which is becoming bigger nowadays, and which I think is really crucial if we're going to move forward. And then I'm going to spend a fair bit of time about talking about individual treatment approaches and the need for us to incorporate adjunct type therapies and kind of a framework by which we can think about doing that. All right, so I'm going to start by talking briefly about the stroke rehab literature, just so you can appreciate it's just the immense size of it and the amount of evidence that we're actually dealing with. And I have this thing called the Stroke Rehab Evidence-Based Review. Believe it or not, we started this back in 2001. I'm real old, so I've been doing this for a long time, and we're now working on our 20th edition. Our partner right now is the Canadian Partnership for Stroke Recovery, and we get some additional funding through Allergan for long-term management. Allergan produces the drug Botox. And basically what we do is we summarize the best evidence for interventions in the stroke rehabilitation. This has become very, very popular. Back in 2004, we were asked to do a similar thing for brain injury. And we have the Arabi out now, which has been foundational for a number of guidelines, and the INCOG guidelines as well, which are the for cognitive rehab and brain injury. And we developed an app, and it has become as well very popular. It's interesting though, the amount of literature for traumatic brain injury, particularly randomized controlled trials, is about 1/10 of what it is in stroke rehab. So stroke rehab is kind of the model that we use, and what we've noticed is traumatic brain injury is about 10 years behind where stroke was in terms of developing its evidence base. You can see it's starting to escalate now, but I think there's a lot to be learned from what's happened in stroke rehab for how we develop that brain injury literature as well. And then SCIRE is kind of in the middle. This is a big project looking at spinal cord injury rehab. We've modeled it again after the Stroke Rehab Evidence-Based Review. It started in 2005. It's a joint Vancouver, London project, or an Ontario, BC project with the Rick Hansen Association, with Janice Eng being the primary leader and myself being the secondary leader on this project. And again, spinal cord injury rehab probably has about 1/3 as many randomized controlled trials as you see in stroke rehab. And it's starting to, again, show the same kind of escalation we're seeing in stroke rehab and allowing us to determine how to practice. So with that, I'm going to just basically give you an idea of what the stroke rehab literature looks like. And this is really the estimated randomized controlled trials in English up until July 1st, 2020. So a year ago, there was actually 3,000 randomized controlled trials in stroke rehabilitation. About 185 of those were due to models of care. We're going to talk a lot about that when we talk about standardization. Surprisingly, about 2,000 or 2/3 of the randomized controlled trials have to do with motor function. So hemiparesis is the iconic feature of stroke rehab. And when you look at it, that is where the vast majority of the research has gone. And so we're going to focus a bit on that because it kind of tells us what things look like when you have a lot of evidence and how you can begin to translate that into clinical practice. Cognitive rehab is the next highest. It has 400 randomized controlled trials, which is quite substantial in the rehab world, but pales next to motor function in stroke rehab. And then medical interventions and psychosocial disorders both have 200 and 250 each respectively. Overall, 3,000 randomized controlled trials as of 2020, which means that as of 2021, where we are now, we're probably up to about 3,400. So it's quite a very large international evidence base that we have to work from. All right, so what I'm going to talk about is something that really has, and I think to set the table for what I want to talk about, one really has to understand how things have developed in stroke rehab, and it's had similar spillover effect in traumatic brain injury and spinal cord injury. And this is this idea of standardization of care. And I think it's been one of the great things that have happened in my career that really define how stroke or how rehab in general has really developed and really improved using best evidence over the past 2 decades. And so I think it's really important when one understands where we're going to go, that one understands where we are or where we have been. And standardization of rehab basically is based on motor learning theory. And this is the idea that rehab has been transformed over the last 2 decades by the concept that if you do repetitive practice of increasingly challenging task-related activities, assisted by a therapist in adequate dose, you're going to get gains in motor skills through brain reorganization. And that kind of nicely.
Sorry, Mr. Teasell. I hear
Can you hear
from
me?
the. Yeah, I hear you, but I hear the interpreter says that it's too fast. Can you slow
Too
down? So,
fast.
yeah, sorry, because
I,
someone is translating in French right now, and
okay.
he cannot do it properly right now.
Okay.
Sorry about that.
I will go slower, which is not my tendency, although I'm told
Sorry.
by many people to slow down. Yes.
Okay, sorry.
All right. All right. So when one looks at how that translates into clinical practice, we know that standardized care focuses on key principles for which there is widespread agreement. And in fact, there's so much widespread agreement among clinicians and scientists that even the funders and the administrators agree. And when the funders and the administrators agree, that's when real change takes place. And the elements of standardized care that are important are the idea of stroke rehab units or specialized stroke care, the idea of intensive therapy, so therapy provided in an intense manner, actually was inspired by the American model, where they 3 decades ago began to institute the 3-hour rule, where every patient got 3 hours of therapy every day, no matter what, or they didn't get paid. So it actually stems from something that started 3 years ago and was shown to have significant benefits, and has since come to Canada. Early access to rehab. So the idea, and I'll talk a bit more about this, that the earlier you get into rehab, the better you do. The idea of task-specific therapy, which for those of you who've been around for a long time, you remember the great Bobath debates with neurodevelopmental therapy, and the idea that even the Bobath type of education had to move towards more of a task-based therapy, because it was so important that that people understood the best way to learn a task was to do the task itself. And then the final one is access to community-based rehab. And those concepts, those 5 concepts, have really spilled out into other areas of neurorehabilitation as well, even though the evidence doesn't exist yet in those areas. The experience from stroke rehab and just the sheer amount of data that's been able to support these concepts has allowed these concepts to be adopted in other areas of neurorehab as well. Now, the first concept, if I can go back, is that of stroke rehab units. And for many of us, there was a great naive belief that if we just developed stroke rehab units, particularly in our larger centers, we would get much better outcomes. And we have been surprised looking at our Ontario data that that's not always the case. And the reason for this is because there's this concept in rehab of structure versus process. And this was first studied by Helen Honig, who's now an editor with the Archives Board. And I remember being, I was an editor on the Archives Board as well. And Mrs. Helen Honig actually with Pam Duncan, did a 2-year prospective trial of 288 acute stroke patients in the VA system at 8 centers. And this is a really important concept. They examined 2 ideas. One is the structure of care. So they looked at the centers from the idea of, how were they organized? Were they organized into just stroke specific units? What was the expertise of their staff? and how sophisticated were they technologically. So that was the structure of care. And then they examined the processes of care. And the processes of care was they measured how well they adhered to the guidelines at the time, which was the AHCPR Yellow Book from 1995 that the Americans put out, which were basically guidelines for stroke rehab processes of care. An excellent book, by the way, and one that I modeled the EBRSR after. And then they studied FIM motor subscale, so the 13 motor elements of the FIM 6 months post-stroke as their outcome measure. And what they found, what they found, much to everybody's surprise, was that the structure of care, so essentially stroke rehab units, was not directly associated with better outcomes. So whether they were managed on a stroke rehab unit or a general rehab unit didn't mean they attained better outcomes. And we certainly have found that in Ontario. Whereas processes of care were associated with better outcomes. So it wasn't so much how you structured your unit that was important, it was how well you followed guidelines and evidence, determined as to how much you were able to improve your outcomes and how much you were able to improve patient satisfaction. So one of the things that really brought up was having a specialized stroke rehab unit did not necessarily guarantee better outcomes. And we have some really good data from Ontario showing that, in fact, in some of our larger rehab units, because they weren't paying attention to guidelines, because they were larger academic rehab units, they were actually getting worse outcomes than the general rehab units that were localized in the smaller communities. And that was a big shocker for us and really caused us to pay a lot more attention to this whole concept of best evidence. And it also points out the importance of culture. And so the key elements that then became important were the elements of what we call processes of care, things like intensity of therapy. So we knew there had to be enough practice to learn new means of achieving lost functions. Task-specific therapy. So it was understood that repetition in the absence of skilled motor learning was not enough for gains to be sustained. There had to be some skilled motor learning for gains to be continued or developed. And then the idea of early therapy, or taking advantage of the brain's greater propensity to learn early on post-stroke. And I'm just going to focus on a couple of these because they're so important, and they're so important to how we currently practice. So in terms of intensity therapy, research has repeatedly shown the benefits of high dose repetitive task practice. Animal studies show the needs for hundreds of repetitions to learn a new movement. The Scottish group, who are quite famous for their reviews, noted that in a review of upper extremity stroke rehab, they found that adequately powered, high quality randomized controlled trials confirmed the benefit of high dose of repetitive task practice. And that type of praise is always hard to get from the Scottish Scottish group, sorry. Van Peppen, who works with Quackle in the Netherlands, actually was able to try to put a number on this and found that additional therapy time of 17 hours over 10 weeks was necessary to see significant positive effects in terms of additional therapy. And the Canadian stroke guidelines have noted that stroke rehab patients should receive a minimum of 3 hours of direct task-specific therapy 5 days a week in an attempt to try and operationalize this idea of intensity. That actually comes from the American experience, where they have the 3 hour rule. The Brits will call it 2 hours and a quarter. They don't have the same 3 hours. Nobody really knows what the right number is. There's just this sense that the more intense the therapy, the better. What the actual number is not fully understood, and it clearly varies from patient to patient. Now, there are challenges in Canada with achieving 3 hours per day intensity of therapy, because we've had that in our guidelines now for over 10 years. Typically, if you follow, even on our best rehab units, if you follow the therapists around and actually measure what they do, you get about 2 hours of therapy a day, 5 days a week. And it hasn't changed much over the past 2 decades. And if I was to go onto my unit right now, which I think is a pretty good unit, and measure the amount of therapy that therapists actually deliver over the course of a day, it's probably going to be around 2 hours a day if we're lucky. It is really one of our big challenges in trying to provide more intense therapy. This is a really interesting study, and I'm going to throw it out there just to kind of point out some of the challenges that we have in terms of intensity. And that's the study by Simpson in Adelaide in Australia, where she actually did a simple study of observing 34 stroke patients the week before they were discharged and the week after they were discharged home. And the patients had an activity monitor they wore for the 7 days before and the 7 days after discharge. And what she found was that when they got home, they were a lot more active than they were on the rehab unit. And you may go, yeah, okay, I can see that. That makes some sense to me. But, you know, when you think about it, they're coming to rehab to be more active. And so it's kind of a wake-up call to me that we need to start thinking about what is it on a rehab unit that causes patients to be less active than they would be at home. And these are things like safety over concerns, you know, like everybody's worried about falling, and we keep telling our administrators, like, you know, people are going to fall in rehab. That's rehab is about putting patients at some risk, right? Challenging them. So there's always going to be a little more falls. We try and avoid them as much as we can, but to some extent they're going to occur, and being over concerned about them can put a damper on rehab. Paperwork, as you know, is always an issue. We spend more time doing that sometimes than we do seeing patients. Motivation, culture, doing things like we've always done them. It argues very strongly, though, for early supported discharge, which I think is an interesting conclusion from this type of research, and sort of suggests that we can do a lot better. Early rehab is a really important concept that I think has really been grabbed hold of. It emerged out of some of the early work by people like Dale Corbett in Newfoundland, who did animal studies that showed that there was a time window when the brain was primed for maximal response to rehab, such that delays in rehab were actually detrimental to recovery. And so it's this idea that the brain has enhanced neuroplasticity early on post-stroke, and rehabbing them will achieve gains that you couldn't achieve with the same amount of rehab later on. It's hard to measure clinically because clinically we tend to admit patients earlier if they're doing better. And so there's a bias that exists there. But if you do try and control for all that, and we did a study on this, there is a clinical association between early admission to rehab and better functional outcomes. The Canadian practice guidelines basically say that all patients with stroke should receive rehabilitation therapy within an active and complex stimulating environment as early as possible once they're determined to be rehab ready and they're medically able to participate in rehabilitation. There is a caveat to that, and that is the trial by Julie Bernhardt, which showed that if you rehab patients aggressively within the first 24, 48 hours, up to 1 week, that you can result in patients extending their stroke, especially in those first few days. And so you always have to take that point of bringing patients early into rehab with a grain of salt. You don't want to be rehabbing them day 1 or 2 unless they're really a very mild stroke. But I think in the Canadian context, those aren't really issues that we have to deal with. All right, so basically, as a result of, let me just see all of this, stroke systems and standardization of care. We have clinical best practice guidelines, which have really standardized all these key elements of care and really pushed them really hard. You can look at the most recent edition of the Canadian Best Practice Guidelines in Stroke Rehab, 2019. And again, have focused on what are key transformative principles for stroke rehab for which there's widespread agreement that we've just talked about. And so that's really made a huge difference in stroke rehab over the past 2 decades, completely transformed stroke rehab care during my time on stroke rehab. But it has caused us to start wondering, now that we've been fairly successful along the lines of standardizing care, where do we go next? And that's kind of where I want to focus on with today's talk. And so one of the limits with standardized care is, as you know, with stroke, we're dealing with fairly high levels of heterogeneity. And so there are limits to the standardization care because of this heterogeneity of stroke. And then I'm going to talk later on about a lack of consensus on individual therapies and who and when we apply them to. But in talking about individualized or personalized care, which is really how we deal with heterogeneity of stroke and probably is the next step in trying to improve the care that we deliver and improve based on best evidence, the kind of outcomes that we're going to be able to achieve above and beyond standardization of care. I've basically listed, 6 areas where I think we're seeing an increasing role for individualized care. I'm briefly going to talk about the first 5, all of which I think have some relevance and are important. And then I'm going to focus on the last one, which is the use of adjunct therapies, which is, I think, where the real gains can be had. So if we look at the increasing role for individualized care, there's things like benchmarking, which is really big in Ontario and has made a dramatic difference to how we provide care. Biomarkers, I'm going to talk briefly about that. Evidence-based algorithms have huge potential, and we're starting to see those develop. Psychosocial factors, which are often ignored, but are really, really important, and I'll show you evidence of that. Continuity of care, something that we forget about in the Canadian context, but there's some really good evidence when you look for it. And then finally, the use of adjunct care. So benchmarking is really been applied heavily in the United States, in Australia, and we have adopted it quite heavily in Ontario as part of our quality-based procedures. And in the province of Ontario, patients are admitted to rehab are expected to be discharged within predetermined time windows that are based upon an algorithm based upon FIM and the patient's age. It's quite complex. It's based on motor FIM largely, to a lesser extent cognitive FIM, and the patient's age to determine how long a patient should stay on rehab on average. And so this has become a real guide for us in stroke rehab in Ontario, and almost everybody adheres to those fixed benchmarks. All right. And the benchmarks, just to give you a brief idea, I'm not going to go into it in detail because it's quite complex, but if you've had a mild stroke, you're expected to be out in 0 to 10 days. If you've had a moderate stroke, you're expected to be out in 11 to 35 days. And if you've had a severe stroke, you're expected to be out in 36 to 50 days. This may seem like it's a bit harsh at times, and the therapists often complain it takes the decision-making away from them, but it's had a dramatic effect on Ontario, particularly with regard to the efficiency of care. The government at one point threatened to tie funding to these benchmarks. And as a result, it just unleashed a huge amount of innovation within the system. Suddenly, everybody had weekend therapy because they had to move patients through the system quicker. Everybody was developing outpatient therapies that they didn't have before, so they'd have some place to transfer the patients. Patients were moving through the system much more quickly. Actually, if you wanted to game the system, the best way was to admit patients earlier because you could get them at a higher level of severity and have more time to work with them. It really dramatically changed Ontario's system. And if you look at Ontario relative to other provinces, Ontario gets their patients into rehab much quicker and moves them through rehab much sooner and has the same outcomes. In fact, I was talking to Sean Duclos at one of his grad I was doing a PhD thesis defense. I was one of the reviewers, and they were showing the Alberta data and comparing it to Ontario data. And we calculated that if Alberta adopted Ontario's system, they would save 25 million for stroke rehab every year. That could be invested in other elements of rehab or rehabbing more patients. So benchmarking has had a dramatic impact upon stroke rehab efficiency in Ontario, and I think is really, really important. And I think we're going to see it adopted in all the other provinces as well. In the United States, they've kind of gone a bit overboard, and their average length of stay on stroke rehab is 17 days. But they accomplish a lot in that 17 days. I think that's a little too aggressive and not where we want to go. The other one, another area where we're looking at more individualized care is biomarkers. And the one that's most often used is transcranial magnetic stimulation. As you know, the work of Catherine Stenier, and showing that, if you introduce this onto a rehab unit in New Zealand, you could better determine what patients had an intact cortical spinal tract, which ones were likely going to make better recovery, and which ones you could use a restorative or a compensatory approach to. And she found that when you applied that onto the ward, you could reduce the length of stay by a week in New Zealand. Now, New Zealand has very long lengths of stay, so I'm not sure how big a deal that was. And I'm always a bit leery about biomarkers. I think they're a little overrated. My joke is always, if you take a basic scientist and combine them with rehab, you always get biomarkers. But I think that they do have a place to play in terms of personalized care as we get more and more sophisticated in our approaches. Now, algorithms, I think, are another way to begin to use evidence to help people to do so. And this is the VIA Therapy app that many of you in Quebec have participated in. Mark Bailey and Stephen Wolf have really been driving this. And basically, it involves an algorithm that helps you to decide how to treat the hemiparetic upper extremity based upon the stage of recovery the patient is at. And so it's been a well-developed algorithm with multiple upper extremity experts from around the world. And so it really has a lot of credibility to it. And we're currently now looking at updating the VIA Therapy app to the 2nd edition and looking at developing one for the lower extremity as well. I think to some extent the INCOG guidelines for brain injury also serve a similar purpose in terms of beginning to develop algorithms to help people to best apply evidence to clinical practice on an ongoing basis. Psychosocial factors we use all the time, but you may just not think of them. Psychosocial factors, certainly this is work that my research team has done, but we're very interested in, one of my grad students was very interested in severe strokes, because we noticed in severe strokes, they're different in terms of rehabilitation. They take longer to achieve functional gains, and they often don't make the same amount of functional gains. Many of them end up not leaving the hospital, end up going to long-term care. And with these patients, a supportive family and resources becomes critical. And so for purposes of study we did back in 2015 with Shalila Pereira, we looked at 190 severe stroke inpatients on our unit and found that of the 121 who, we found that only one of 121 patients were discharged home in the absence of a caregiver. So 39 patients did not have a caregiver, and only one of those was discharged home. Of the patients that had a caregiver, 120 out of 151 were discharged home. And it became quite apparent to us from this study that for severe stroke patients, people with that initial FIM score in the first few days of under 40, or the FIM score of say under 50 or 60 in the initial phase, in the first week, those patients are not likely going to go home if they don't have a caregiver. And so for the frail elderly patient who's a severe stroke, bringing him onto rehab starts to become a question, since they're probably going to be sent to long-term care. And in long-term care, they don't tend to follow up with their rehab, and they tend to lose their gains. And so it initiated a debate with us as to whether these patients were actually appropriate for rehab or not. And that debate has yet to be resolved. But certainly there's limited rehab success for elderly severe stroke patients with no family supports. Turning it around the other way, though, is that alternatively, rehab of severe stroke patients with strong family supports was more likely to be very successful. And those were the type of people you wanted to really invest your resources in, because those were the ones you're most likely going to get home. Interestingly, and I just showed you that graph on the right side, we found individuals who had caregivers actually made more significant FIM gains on the unit. So that was really interesting. If they had a caregiver, they were more likely to make FIM gains. And this is after we had accounted for all the other factors that might bias that data. So we were trying to figure out why that was. I remember asking we actually had a focus group of the patients, the staff, and we asked the staff why that was, and they said it's because families tend to motivate the patients when they're there, When we asked the family members why it was, they said, well, when we're there, we tend to motivate the staff. So I don't know which one it was, probably a bit of both, but it was an interesting finding. And again, a predictor of who does better on rehab, and something that we actually do use when we make decisions as to who comes onto rehab, but we don't talk about it as a necessarily within terms of within evidence like this. Another interesting thing that's psychosocial, again, that we don't talk a lot about, but has really been showing up more and more in the literature, is this idea of patient preferences and motivation. And so one of the most challenging problems in dealing with recovery is limited or non-use of an affected extremity, even as it begins to recover. And so while motor capability is the major factor, non-use behavior can be explained in part by limited expectations and confidence for task success on the part of patients. It's been shown that up to 50% of patients post-stroke don't incorporate the paretic hand into performing tasks at home, even when they've been shown they can do it in rehab. And 27% of stroke patients who make a full recovery on the Fugl-Meyer scale reported reduced use of the hand in terms of ADL activities, even though they made a full recovery. And a lot of this appears to be related to self-efficacy. And this has been seen in the constraint-induced movement therapy group, where they've shown that motor improvements where patients are forced to perform tasks with the paretic arm are seldom generalized into the home environment if they're just done in isolation while on the rehab unit. However, Gauthier showed that if you added what's called a transfer package, where they spent a lot of time emphasizing how this would be then utilized when they got home, and had somebody when they got home work with them on terms of actually implementing the changes that had occurred with constraint-induced movement therapy in the rehab unit, that made a huge difference in terms of whether they actually incorporated the changes that occurred in constraint-induced movement therapy when they went home into their day-to-day practice. And we probably don't spend enough time thinking about this type of stuff. And it does point to the importance of outpatient therapy as well when we're done our inpatient therapy. And this is the final one before I get to the topic, what I really want to talk about. And this is this idea of continuity of care, which I think we're not particularly good at in Canada. And this comes from the early supported discharge literature, which is really interesting. This was a review by Fearon and Langhorne in the Cochrane back in 2012, but I continue to use it because it's really useful. And what they showed was that early supported discharge, most of you are familiar with early supported discharge is, it's just discharging patients to get rehab at home at an intensity similar to what they would get on a rehab unit without the nursing care. And so it's much less expensive. Obviously, you don't have the nursing and the hoteling costs, which are about 75% of your costs on the rehab unit. And so for the patient that's getting close to getting home, if you can have this type of resource available, you're more likely to be able to rehab them at less cost when they go home. So this is very popular in England, where most of the trials have come from. Not been able to make it work in Canada because we've not been able to manage our wait list properly, but that's another issue. I think Calgary is probably the only place that's really come close to an early supported discharge plan. But anyways, what they showed was that early supported discharge versus conventional care did improve outcomes. But interestingly, when they divided it up into 3 different types, they found that most of the benefit came in the randomized controlled trials that looked at the therapist who was in the inpatient unit providing the early supported discharge at home. So the same therapist who provided inpatient therapy provided the same rehab at home. All right. And so that resulted in dramatic and significant difference in terms of how well patients would do because of that continuity of care. Where you had the inpatient and the early supported discharge team working closely together, there was a trend to benefit. And where the inpatient team and the early supported discharge team did not work well together, you just sent off a report, for instance, telling them how they did, a discharge summary, and then the other team would have to read it, actually was a trend to less benefit. And what it really points to is that it's just not enough to provide the resources, but continuity of care really matters. And so another area we need to start thinking about, it's very personalized. that can help to improve various outcomes. All right, the final thing I want to talk about, though, is this idea of deciding on individual adjunct treatment approaches, and this has become my new focus in sort of my career. I've become very interested in this concept of adjunct therapies and how we can utilize adjunct therapies to try and improve the care we're providing. And I'm going to stick with the upper extremity motor treatment approaches in stroke. And the reason I'm doing that is because that's where the most data is in all of neurorehab. There are, up until June 30th, 2020, there were 1,125 motor RCTs for the upper extremity alone. All right, in stroke rehab. That's huge. It's just huge. Lower extremity is about 800. There's nothing that matches it anywhere in neurorehabilitation rehab. So it kind of gives us a glimpse of how we can use evidence down the road. And basically, I'm going to divide the interventions into two groups: basic motor therapies and then adjunct therapies. And again, I'm doing this in the context that there is a real sense in stroke rehab research that we're doing a lot of research, but our results are plateauing and we're not moving forward clinically. There's a real sense of that, like we're kind of stuck. You know, with standardization of care, we did a lot of really cool things. We've added some other components I just talked about, but there's a sense that there's something that we're missing, particularly given all the evidence we have. And I'm going to try and point out what I think that might be. So I'm going to start by talking about basic conventional therapy approaches for upper extremity paresis. This is what I talked about under standardized care. This is rehab, is basically therapy is ideally delivered intensively, started early, and focused on tasks important to the stroke patient, and then basically involves one-on-one practicing with a skilled therapist. Interestingly, these basic therapies are well studied, but they're only like less than 10% of all the upper extremity motor RCTs. And I've listed them there in terms of the number of randomized controlled trials and the total subjects. Many of them are smaller trials, although there's about 25% of them are multi-center trials in each of the groups. But you can see that there's a lot of evidence for this, but it actually surprisingly accounts for probably only about less than 10% of all the randomized controlled trials we have for the upper extremity. The rest of the data is actually accounted for by what I call adjunct therapies, and that accounts for about 91% of RCTs. The reason I'm going to really focus on them is because what I have noticed in traveling around the country and traveling around other countries is that they're not used a lot. Even though they're 91% of the evidence, they're not used very much at all, with the exception maybe of Asia, where when you go to Singapore or Seoul or Hong Kong, you'll find that they're much more likely to be using these technologies frequently. But in other centers, we don't find them being used regularly very often. And I'm going to talk a bit about that. So there's really limited consensus on what individual adjunct therapies should be applied to facilitate upper extremity motor recovery. I chaired the last two clinical practice guidelines in stroke rehab that looked at motor rehab in Canada. And the Canadian clinical practice guidelines, along with other clinical practice guidelines, are really uncertain on how to incorporate any of these into practice. And so what you'll see is that you may want to consider, or you may want to think about, or, you know, and it never gives any context on who they're best for, because I just don't think we've really developed that kind of thinking or that kind of clinical experience, because we're just not using a lot of these adjunct therapies at all, even though they represent probably the next step in terms of improving stroke recovery. And my argument has been that to utilize these treatments, we should at least start off with some sort of framework that's clinically intuitive and that therapists can use. And so this is the framework that I have developed. I actually thought about it for a long time, was starting to come up with it, and then saw it in a Korean journal in Korean. And interesting, the Koreans are probably the most advanced right now in terms of randomized controlled trials for motor recovery and stroke by far. They produce the most randomized controlled trials. But, it was in a Korean journal, so some of the ideas I've taken are not entirely mine. But, it's this idea that, approaches can be, we can do two different approaches to it. One is we can prime or stimulate approach, or the priming or stimulation approach, where we stimulate the brain as an adjunct to standard therapy to try and accentuate recovery. And I'm going to talk a bit about that. The second one is a facilitatory approach, where we tend to facilitate peripherally, to use treatments that facilitate the hemiparetic arm peripherally to accentuate recovery. Again, remember, for both the primers and the facilitators, this represents about 91% of the evidence that we currently have for upper extremities. So these things are very well looked at, all right, but not very well utilized, and certainly don't have a good framework for utilizing them. Interestingly, therapists tend to like the facilitatory approach a bit more than the priming approach. That's certainly been my experience. But, when I sit down and talk to therapists, they are really, really interested in trying to begin to apply these. And so I think there's a real desire out there to start utilizing adjunct therapies a lot more as a way of trying to improve upon standardized care. And so I'm going to first talk about the priming approach. And this approach stimulates the brain as an adjunct to standard therapy to accentuate recovery. And we can divide it into three different categories: repetitive magnetic or electrical stimulation, brain stimulating therapies, and medications used to improve recovery. And so under the repetitive magnetic or electrical brain stimulation, we have, as you know, repetitive transcranial magnetic stimulation, which is beginning to get more and more interest, still not being regularly used on rehab units. But if you go to Asia, they'll frequently use it on their patients on a regular basis. We're just not quite there yet, but it looks very promising. Transcranial direct current stimulation, you can actually buy kits for these now. Some of my patients do, and utilize it themselves as an outpatient. But it's another potential treatment that perhaps doesn't require the same degree of skill of a repetitive transcranial magnetic stimulation, or the same cost. Theta burst stimulation, which is a form of RTMS, and invasive cortical and nerve electrode implant stimulation, which we're not going to get into. These are things like vagal nerve stimulators and direct cortical stimulation under the skull. We're not into that, but some people are actually studying that. This has been very well studied, and certainly represents, I think, a really cool area of research, particularly because it involves technology in terms of improving our outcomes. And the Canadian best practice guidelines say non-invasive brain stimulation may be considered as an adjunct. So it doesn't really give a ringing endorsement, and doesn't really say when and how it should be utilized. And we don't really have the clinical experience yet to be able to guide us there. I was talking to the Malaysians about the same thing. I've given this talk several times and over Zoom, and I was talking to the rehab therapists and docs in Malaysia. And, some of the poorer centers said, well, we don't have money to buy things like brain stimulators. And I said, well, you don't always need a lot of money. If you can't afford an RTMS, use a mirror. And so we've seen a lot of these brain stimulating therapies out there that are low cost that can also accomplish the same thing. They prime the brain for standardized therapy care. So things like mirror therapy or bilateral arm training, mental practice or action observation, for which there's very strong evidence, as you're going to see, or adding different cognitive elements, virtual reality being the one that's become the most popular. And again, these are all things that can help stimulate the brain to improve upon our outcomes from standardized care. And they're not expensive. You can do them relatively inexpensively. Medications have also been shown to improve care. I'm not going to spend much time on this, but antidepressants, in particular fluoxetine, have been suggested to improve motor recovery. Some of the more recent trials have been a little less compelling. But nevertheless, there is some evidence, particularly for things like antidepressants. Cerebrolysin, which is not in Canada, but is used a lot in Eastern Europe, and has become very popular in Asia. CNS stimulants like amphetamines all can have some evidence suggest they might be future adjuncts. We've tended to not be real proponents of using medications before therapy, but in some jurisdictions, this is commonly done. All right, now moving on to the facilitatory approach. This is something that is also for which there's a substantial amount of evidence, but it's different. And I divided it into 3 categories as well: specific exercise therapies, sensory stimulation, and technologically facilitated exercises. And I said before, facilitatory approaches tend to be a little more popular because they're more similar to what therapists are currently doing now. And so specific exercise therapy seems to be dominated primarily by constraint-induced movement therapy. We have well over now 100 randomized controlled trials, and as you'll see, very powerful in terms of its benefit. Surprisingly not used very often. And it's always puzzled me why. Therapists don't like it, patients don't like it. And yet, despite the fact that it's a useful treatment, we find that there seems to be a weird adversity to utilizing it in most clinical settings. And even on my own unit, I'm constantly discussing constraint-induced movement therapy with my patients and with the team. And boy, they give me the funniest looks, when I say, this is a good patient for constraint-induced movement therapy. I think it's because the patients get very frustrated with it. And I think the therapists prefer other methods over it, but it is a very powerful treatment. For some reason, we're having a great deal of difficulty incorporating it into clinical practice. Sensory stimulation has a surprisingly large amount of data, things like acupuncture, biofeedback, TENS. Its impact doesn't seem to be as powerful as other treatments, and it doesn't tend to end up in the group that has the highest evidence, but nevertheless, they are another option because it's particularly in patients that have problems with neglect or sensory loss. And then finally, technologically facilitated exercises that everybody's interested in. Everybody's saying to me, should I buy a robot? Should I not? Robotics have been heavily studied. And everybody seems to get a robot and then they want to do a randomized controlled trial. And then and which unfortunately doesn't really show as much benefit as other treatments. Robotics have not been that impressive, to be frankly honest with you, but neuro and functional electrical stim have been shown to be quite significant in terms of their impact. And so, we've got priming approaches and we've got facilitatory approaches as a way of trying to look at what can we be doing next with our patients that we tend not to do a lot of now clinically, for which there is substantial evidence. Now, the final thing I want to answer is, do these treatments make a difference? And, we actually look at these with meta-analyses, but we've kind of, because we have so much data in stroke rehab in the upper extremity, we've actually proposed a new strategy, looking at them with network meta-analysis. With a network meta-analysis, with the typical meta-analysis, what you do is you look at an intervention and you study it with all the different outcomes. With a network meta-analysis, you look at one outcome and how it's impacted by a number of interventions. And so we choose the Fugl-Meyer for our first network meta-analysis. And the Fugl-Meyer is now recommended, as you know, by the stroke research group for all stroke rehab motor intervention trials, both the upper and lower extremities. It is an impairment measure, which makes it fascinating because there's a big argument now whether rehab even impacts impairment or not. And so anything that changes the Fugl-Meyer, you could argue, does seem to have an impact on impairment. And the measure has been shown to have good reliability and construct validity. And so we looked at it with a network meta-analysis. We wanted to look whether at all interventions where there were 3 unique studies where the intervention was compared to conventional therapy. So that was important. 2 things: they had to have the Fugl-Meyer test and they had to compare the intervention to conventional therapy. And we also looked at where the Fugl-Meyer was used and therapies were compared head to head. So we also incorporated that into the network meta-analysis, and we found 150 randomized controlled trials met our eligibility criteria. And we were able to develop this kind of a forest plot showing the various treatments and showing the difference, the mean difference between conventional therapy and the intervention. And you can see that some, like constraint-induced movement therapy, have a much more dramatic effect in terms of than say robotics involving the hand. This is kind of a diagram of what we did. The larger bars suggest where the thicker and longer bars are, is where the most randomized controlled trials were. Where the connections are, where the head-to-head trials were, and where the colored bars, where it's colored, it shows where the connections were, or the head-to-head trials were that were multi-centered. And so from this, you're able to develop this graph, which shows the mean difference between the intervention and conventional care. And this is for all interventions at all times. We then looked at them at different times, less than a month, less than 3 months, and more than 6 months. I'm running out of time, so I'm just briefly going to give you the summary. We came up with this, shows the mean difference. We wanted to see whether it met the minimally clinical important difference threshold for the Fugl-Meyer. And what we found was these are the treatments that seem to have the most benefit at different times. These are treatments when compared to conventional care, resulted in a mean difference that was minimally clinical important difference for the Fugl-Meyer in terms of changing the outcome. And so the type of treatments that seem to have the biggest impact overall, when you looked at all the trials, functional electrical stimulation, a modified constraint-induced movement therapy, and motor imagery. When you began to look at them within a month, you can see that the mean differences are much higher. So that the impact of therapy was much greater, these therapies in the early phases, first month, for instance. And you can see that bilateral arm training, functional electrical stimulation, and modified constraint-induced movement therapy really did come up with a threshold that was higher than the highest MCID in the clinical trials. And you can also see that the other ones, action observation, TDCS, hand exoskeleton, theta-bear stimulation, RTMS, always also showed differences within that first month. Within the first 3 months, sort of similar to within the first month. Same sort of thing, modified constraint-induced movement therapy, functional electrical stim, and bilateral arm therapy had the biggest benefit. When you looked at the chronic phase, more than 6 months, the only data that showed up so far is mirror therapy and motor imagery. And I wouldn't have expected that as the two things that seem to make the greatest difference in terms of the outcomes for upper extremity post-stroke. The reason I show this is because this just shows you what we can do for the Fugl-Meyer. The next we want to look at is, for instance, the ARAD, or the arm reaction arm test, which is more of a functional scale, or the Wolf motor function test, which is more of a functional scale. We've started to look at dexterity as well, using the box and block and the 9-hole peg test. And we can begin to hopefully develop the first use of evidence to try and determine for what patients, at what time, for what outcome we want, what treatment based on the current of evidence is most likely going to have the greatest effect. So it's pretty exciting. We're kind of at a stage now where we can start thinking about not just using adjunct therapies, but hopefully as time progresses, we can begin to determine what adjunct therapy is best for what patient at what time. And so just to give you a summary, stroke rehab has the strongest evidence base of the neuro rehab groups. First principles in stroke rehab are generally agreed upon and established as standardized practice. Operationalizing is still an issue and still incomplete, but we're well on our way, and it's made a huge difference to the type of care that we provide. Primers and facilitators of recovery provide an approach to rehab, which introduces adjunct treatments into stroke rehab care that generally are not used a lot, and which probably we need to start thinking about how do we utilize these on a more frequent basis to improve patient outcomes. And we need to develop evidence-based guidelines to determine the use of adjunct therapy in stroke rehab. And that's it. Thank you very much.